Welcome to the session, PTSD and Chronic Conditions. My name is Nicole Scappi. I work at NHF and I have a bleeding disorder. I'm excited to introduce our expert, who is a clinical social worker at the Boston Hemophilia Center, Amanda Stahl. Amanda earned both her bachelor's and master's degree from Boston College. She has been practicing social work for over 10 years and has worked in a variety of clinical settings. She currently serves on multiple working groups and strives to improve the quality of life of those with bleeding disorders. Now, before we begin, I wanted to quickly discuss how you can get the most from this session. So number one, feel free to utilize the chat box during this session and ask any questions you would like to the speaker. Number two, please fill out the evaluation at the end so that we can get your feedback. And number three, all of this presentation will be recorded so you'll have access to it at a later point in time. So with all of that being said, it is my pleasure to pass it over to Amanda.
Thanks, Nicole. So like Nicole said, my name is Amanda Stahl, and I'm the social worker at the Boston Hemophilia Center, and I'm going to be talking about trauma and post-traumatic stress today. So I gave a similar talk last year at NHF when the world looked a little different than it does today, and it's hard to talk about trauma without acknowledging the impact that the coronavirus has made on all of our lives over the last 6 months and, will continue to make. And while we can't blanketly call kind of this experience traumatic for everyone, I think it's definitely safe to say that it has been traumatic for some. And the focus of this talk is not going to be about COVID specifically, but I am going to talk about illness-induced PTSD. And I hope that some of the coping strategies for PTSD that I talk about can also be potentially utilized for stress management and anxiety more broadly, especially during this uncertain time. So before we talk about illness-induced PTSD, I'll tell you a little bit about why it's interesting to me. So last year, I attended this social work continuing education seminar at the hospital where I work. And the seminar focused on the experience of trauma for survivors of domestic violence. And because survivors of domestic violence are mostly women, the session kind of left me wondering how trauma might impact my patients, who are mostly men. Would the impact be the same? Would trauma manifest differently? So then I started thinking about not only how trauma is, experienced via gender, but just about our patient population's life experience more broadly, and just the amount of trauma that our patients have faced, both individually and collectively as a community. And I thought there must be some research about PTSD among patients with hemophilia. But when I turned to the research to start looking at the prevalence of trauma in this population, I found no data, which was really surprising, just given what this community has been through. So I decided to embark on a PTSD-focused research project, which I will tell you a little bit about today. Because if we know more about the prevalence of PTSD among our population, we might find that it's not only helpful but necessary to offer better treatment modalities within our clinics. So while there's no specific research on how PTSD might manifest for our hemophilia patients, I did find some useful information on how PTSD can manifest for survivors of acute and chronic illness more broadly, and I will elaborate on that more today. So I have no disclosures. So it's important for us to first take a few minutes to talk about trauma and PTSD more broadly, its origins, how it's currently diagnosed, and why that all matters. So my hope for this session is that by providing some clinical indicators of post-traumatic stress, we might better come to recognize the symptoms as PTSD, not something else, so that we can acknowledge it and find some better ways to manage it and cope with it. PTSD is a condition that extends much further than veterans and people who've experienced combat, which is something, I think, a way that we've kind of thought about it historically. So, and why does this matter? First, well, we really need an accurate diagnosis, right? So we can actually appropriately treat people. I think that goes without saying. But second, PTSD doesn't just affect you. It impacts your spouse and your family. So take a minute and ask yourself, are you so busy kind of thinking about a past traumatic experience that you aren't able to focus on the present and on your relationships? Are you so busy waiting for the other shoe to drop that maybe you become angry or irritable or reactive all the time? Are you emotionally closed off? I mean, these might be symptoms of trauma, and they might impact people around you. So PTSD also impacts your brain. It dictates how you react and informs how we regulate our emotions. And finally, and maybe most importantly, traumatic stress impacts our body. There are many studies that show that PTSD actually increases the risk of certain cardiac diseases, chronic pain, and some autoimmune diseases. So it's important to take care of it. And I want to acknowledge that some patients suffer from PTSD symptoms as a result of trauma having kind of nothing to do with their hemophilia. But for the purposes of this presentation, I want to focus mainly on illness-induced trauma. So what is PTSD? So, well, humans have kind of been exposed to trauma right throughout history via saber-toothed tiger attacks. All the way, we've heard of shell shock after World War I. It wasn't until after the Vietnam War in the 1970s that psychiatrists and psychologists started noticing a trend in psych presentations among Vietnam vets returning from war. And they're all having the same symptoms, including flashbacks, nightmares, anger, hypervigilance. And while these symptoms were certainly not new, in 1980, the American Psychiatric Association decided to label this group of symptoms as post-traumatic stress disorder in their diagnostic manual, known as the DSM. So this was the first time that trauma symptoms were recognized as clinically different than symptoms of depression, in that the precipitator or antecedent of the symptoms occurred outside the individual. And most people can cope with ordinary stress. It happens, we all face stress in our lives, but our brains become overwhelmed when confronted with a traumatic stressor. And trauma can actually kind of change the way our brain responds. So what is post-traumatic stress disorder? So it is a mental health condition that can occur, that can occur in people who've experienced or witnessed a traumatic event. And a traumatic experience can be defined as any extremely stressful event that challenges our ability to cope. So we think about serious injury, threatened death, sexual violence, etc. And the experience of trauma can vary based on age, culture, and socioeconomics. We all process trauma differently depending on many different factors and life experiences. So what is post-traumatic stress disorder? So, So I know this is a lot of statistics that I'm going to throw at you, but while about 8% of adults in the US will develop PTSD at some point in their lives, according to the Veterans Administration, not everyone who experiences trauma goes on to develop post-traumatic stress symptoms. Actually, the majority of people who experience a traumatic event do not go on to develop PTSD symptoms. But there is a really wide variety of life circumstances that informs how we react to and internalize traumatic stress. So the estimated risk for an individual to develop symptoms of PTSD following a traumatic event can range really broadly from 1 to 50%. So like you and your sibling could both be in the same car accident together, and it's not certain that both of you will develop symptoms of PTSD. Maybe just one of you would, or neither of you. Or I guess both. So it really depends on, various circumstances, like I said, culture, age, socioeconomics, social support, and past traumas. So approximately 15 to 35% of patients with chronic pain also have PTSD. And this is a really interesting fact, right, for our hemophilia patients, many of whom suffer from chronic pain. And according to the research, the occurrence rate of PTSD in survivors of acute life-threatening medical events like heart attack, stroke, cancer, etc., is about 12 to 25%. And about 1 in 5 survivors of people who experience a stay in the intensive care unit also go on to develop symptoms of PTSD. And there's limited knowledge, like I said, regarding the prevalence of PTSD for our hemophilia patients. So how is it diagnosed? So how PTSD is currently diagnosed is through looking at the following symptoms. First, there must be a stressor or traumatic event, which precedes all the other signs and symptoms. PTSD has historically been associated with veterans, and so we think about combat as a traumatic stressor or another similarly stressful event. After the stressor, the next determinant of PTSD is intrusion symptoms. So intrusive memories, traumatic nightmares, flashbacks. Then we have avoidance symptoms, which is kind of making all attempts to avoid distressing memories, thoughts, or feelings, people that remind them of the event. So avoidance behaviors are essentially an effort to withdraw from situations that produce trauma-related feelings. And this symptom can be really dangerous because it's dangerous to suppress those emotions. They're there to protect us. For example, fear exists to tell us that we're in danger. And experiencing sadness might show us what's important in our lives. And healing from PTSD is really about learning to tolerate and sit with some distressing emotions. So anyway, the next one, negative alterations in cognitions and mood. So this symptom has a super clinical sounding title. I'm going to try to break it down for you. So have you ever in your head think this through, maybe texted, say, your boyfriend or your girlfriend or your sibling and not gotten a response and thought, that's it. They hate me. And it's because I got a bad haircut. It's because I said something awkward or whatever illogical reason you can come up with. So this symptom is about making up a story to explain certain events, but the story is usually distorted. It's not based on any facts, right? Like maybe the person you texted is out running and will get back to you when they can. It has nothing to do with you. And this happens a lot in trauma survivors. And it can have a really negative impact on your relationships and your life, obviously, right? So you can imagine if you think through that your significant other hates you because they didn't respond to a text and maybe you act cold toward them and they break up with you, and you can see how this can be a dangerous cycle. So this happens a lot. Anyway, the next one, alterations in arousal and reactivity. So one might think of a veteran in survival mode who's very easily startled or hypervigilant and subsequently likely has kind of problems concentrating, problems sleeping. They might be irritable, aggressive, or angry. You're always waiting for the other shoe to drop, and that takes up 90% of your concentration, making it kind of hard to tolerate anything else. Anyway, so one thing I notice about all of these symptoms in traditional PTSD is that they are rooted in the past. So you can kind of see a timeline here, right? A traumatic event takes place one time in the past, and then you're bombarded with nightmares and flashbacks of the event, and then avoid all feelings or emotions related to this event. But the trauma is over, and that's not necessarily the case when you have a chronic illness. And so PTSD looks different for our patients because even though you might have experienced maybe one specific traumatic event related to your illness, you're still dealing with a chronic and ongoing illness and reminders of that trauma. So rather than a one-time past confrontation with mortality, patients who have an acute or chronic illness are dealing with an ongoing confrontation with mortality, which is sort of the root of all other symptoms. Anyway, so the symptoms of PTSD when you have a chronic illness might not fit neatly in the boxes of diagnostic criteria that I just laid out for you. This doctor, as seen here, Dr. Donald Edmondson from Columbia University, who has done extensive research on illness-induced PTSD, came up with a way to explain traumatic responses due to medical events like stroke or heart attacks. And he calls this sort of explanation the enduring somatic threat model, which I'll talk about in a minute. So while no one has looked at how trauma manifests specifically for hemophilia patients, we can use Dr. Edmondson's model to better explain some of the symptoms that I've seen our patients exhibit in clinic. So using this model, the stressor or event leading to PTSD symptoms might be any number of events occurring in a patient's life. And I'm not saying that any or all of the events I listed necessarily cause PTSD, right? Like I said earlier, not all people who experience trauma go on to experience post-traumatic stress. But these events can absolutely be traumatic and alter your ability to cope. And this isn't a live event. And I'm sure all of you in the audience could come up with many more examples than me, but some examples of a traumatic stressor or event in the life of a hemophilia patient are, of course, acquiring an infectious disease, the threat of death, the loss of a loved one, prolonged hospitalizations, disfigurement, etc. Intrusion symptoms, like flashbacks and nightmares, occur because of a past trauma in a typical presentation of PTSD. But for people who've experienced acute or chronic illness, intrusion symptoms might be more future-oriented rather than flashbacks. So we have fear of worsening symptoms, fear of accidents, hospitalizations, worsening joints, fear of passing along disease to future generations, right? Like some of our patients don't want to have kids. That happens a lot. Developing an inhibitor, what that might mean. This is where I'd like to mention that I sort of think of PTSD as like an ugly cousin of anxiety and depression. All these symptoms of fear might sound like anxiety, but because they are caused by an external traumatic event, they are most likely symptoms of PTSD. So avoidance symptoms in this model can definitely look the same as they do in traditional PTSD, right? We might be avoiding uncomfortable or distressing feelings or people associated with trauma, but because illness affects your body, you might also try to find a way to avoid your body via maybe increased substance use or abuse, maybe non-adherence to treatment or follow-up care. You might feel anxiety about and avoid doctor's appointments. It might be stressful or distressing to, consume media like TV shows about hospitals. Negative alterations in cognition's mood. Again, this is the most clinical title to describe the development of just unhelpful thought patterns. So some examples of negative beliefs that might affect hemophilia patients, right? Like I'm a bad person, which is why I have hemophilia or acquired HIV or lost a loved one. Or I am bad because I've caused my family to worry about me because I'm sick. So unwarranted blame is just a common symptom, maybe blaming a spouse or family member unnecessarily. We also tend to blame ourselves unnecessarily for things, that we have no control over. Alterations in arousal reactivity. So again, in traditional PTSD, we think of a veteran on high alert experiencing hypervigilance because they believe something bad will occur. They're waiting for the next kind of bomb to go off. And in illness-induced PTSD, it's not that different. You might be on high alert that something bad will occur, and you might be experiencing some anger, problems sleeping, irritability as a result. The main difference is that when you have a chronic or life-threatening illness, your vigilance might be tied to something more somatic, right? Or like something of the body. Maybe like a bleed might trigger you to be on high alert and display some of these symptoms. So if any of this kind of sounds familiar, what I'm talking about, know that you're not alone. I'm hearing these symptoms in our clinic all the time from our patients, which is sort of why I decided to do some research on it. And we're currently undergoing a research project regarding the prevalence of post-traumatic stress disorder and post-traumatic stress symptoms in adult patients with hemophilia A and B. And there are 3 HTCs participating in data collection. And we've collected some data, but we are very early in the research process and had to stop everything in March when we went on lockdown and are at home now. But we have collected a little data and I want to share just a little bit with you. And I realize this isn't a live presentation again, but I want you to think about this question and try to guess the answer. So about how many research participants, again, adults with hemophilia A or B, mild, moderate, severe, experienced at least some symptoms of PTSD in the last 30 days. And remember that we haven't surveyed anybody since COVID, so this was before March. So the answers are none, some, most, or all. So take a moment to guess. So I don't know if this is surprising or not, but most of the patients that we have surveyed so far have experienced some symptoms of post-traumatic stress. So I can't discuss research findings further because, our sample size, again, is so small and we're still collecting data. But so far, these findings just indicate that we need better trauma trainings and screening tools for providers. And we need to start thinking about ways to kind of help our patients cope with post-traumatic experiences. So now that we understand the prevalence of PTSD and some signs and symptoms, I am going to talk a little bit about coping tools. But I first wanted to make a plug that it's never too late to try and get help. Life is super messy, and it's okay to accept that reality without succumbing to the shame and guilt that setbacks create. If this book title sounds like you, that's totally fine. If you've tried to start the healing process before and it didn't work, that's okay. Don't let that failure or fear of failure stop you from figuring out a new way to deal with an old problem. So there are lots of angles and approaches that we can take to start the process of coping. And trauma is super complex, as I just laid out. You might be experiencing trauma related to something that happened as a result of your bleeding disorder, but you're also a human being full of life experiences and love and loss. And all that guides not only who we are, but also how we cope. You don't live in a bubble. And because everyone's life experience is so different, so is our approach to healing. Also, as we discussed, there are a lot of different co-occurring symptoms to treat, right? We had all those different symptoms. And we learned that trauma symptoms impact both mind and body. So treatment might try to address both. Trauma, especially medical trauma, takes away this notion that we have control over our lives. So treatment might be focused on regaining some control and recognizing what we have control over and what we don't. And one way to do that is through mind-body work like yoga and mindfulness, which I'll talk a little bit more about. But therapy can also be a helpful tool when coping with trauma. And finally, sometimes psychopharmacology works, medications that you can take, but usually not alone, the research has shown, usually in conjunction with therapy or some mind-body work. So I'm adding yoga to the list of ways to deal with trauma because it is one way to practice connecting body to mind through breaths and postures and movement. But I'm also acknowledging that many of our patients cannot utilize this practice because of joint damage, etc. Mindfulness meditation is another great way to start noticing the mind-body connection. The goal of mindfulness is to bring your attention to the here and now by focusing on your breath and your body. And when we notice our body, kind of how we are feeling in the moment, breathing, etc., and pay attention to it, we can increase our control over our body and over our reactions. And we can start to learn to respond rather than react. And actually, so the social worker at a previous NHF conference presented this sort of genius way to incorporate mindfulness practice, in our day-to-day lives. And she kind of said to identify an environmental cue. So sitting down for a meal, opening your closet door, showering, touching a doorknob, or whatever it is, as a reminder to reset your posture, take a deep breath or two, and focus on it, all the way in and all the way out. I think we kind of get bogged down sometimes. Meditation sounds like something you have to commit a long time to every day, and it's not. It can just be a couple minutes, of your day. And just something quick that you do to kind of reset. Remind yourself that here you are in this moment, in the here and now. So, I'm just including some apps and resources that, can help guide mindfulness practice, and I'm including them here so you can take a look if you're interested. I think it's helpful for everyone, not only just people who have suffered from PTSD. Therapy can also be an effective tool to deal with past traumas. And I love this quote about therapy by Dr. Bessel van der Kolk, which I will read. The goal of therapy is to help people acknowledge, experience, and bear the reality of life with all its pleasures and heartbreak. The greatest sources of our suffering are the lies we tell ourselves. And this quote is from his book, The Body Keeps the Score, about trauma and recovery. And even though the book does not focus on medical trauma, it is a great book to learn more about trauma and adverse childhood experiences if you're interested. And this quote really resonates with me because people have a notion of therapy as, curative treatment for PTSD or anxiety, right? Like, I have a problem, I'm going to get cured. And it can be really defeating to have that mindset. You can't change what's happened to you, but you can change the narrative you've developed around the trauma and kind of learn to live with it and cope with it better. It's not about forgetting the past, but rather kind of lightening the weight of the past and letting go of shame and guilt associated with it so we can live a fuller life and have meaningful relationships. And there are many kinds of therapeutic treatment modalities, but even more important than the therapy you choose to partake in is to find a collaborative, therapist that you can trust. And I know that can be difficult sometimes, but it's important to learn in therapy kind of how to reframe trauma. How did you survive rather than, how you were hurt? You're not helpless and you did something to recover. Was it physically, emotionally? What was it? Again, healing is about learning what we have control over and what we don't. And we're all resilient. And it's okay for someone kind of remind us of this and to help us promote and exercise our own resilience. Cognitive behavioral therapy is just, one type of therapy that has shown to reduce symptoms of trauma by helping patients gain awareness of how thoughts, feelings, and behaviors are linked back to the trauma. So in the meantime, while you're starting to practice mindfulness and maybe get a therapist or whatever else, here are some other basic coping tools to utilize. So first, just acknowledge the traumatic event and what you have been through. Acknowledge it for yourself. It's helpful to have support and tell people in that support network. Authenticity goes a long way toward healing. Connect with others, especially those, who've shared the stressful event or maybe experienced similar trauma through support groups, maybe blood brotherhood. This community is overwhelmingly supportive. And there are just so many opportunities to share our stories, with each other. So I hope we can all take advantage of that. Sleep hygiene. So this is true for maintaining all mental health. And it basically just says, put your phone down, pick a time to go to bed every night, not 1, 2 in the morning, maybe like 11, 12, whatever you can do to kind of move that, time a little bit earlier and so that you can get a full night's sleep. And finally, commit to something personally meaningful and important every day. And so I recommend a lot of our patients have a gratitude journal. Gratitude journals aren't just ways, to say, I'm grateful for, my family. It's to think about your day, what you're grateful for in that moment. And it's really nice to, write that down. And writing down your thoughts kind of helps you to reflect rather than perseverate on the past. It's a really helpful tool to use. So anyway, that sort of concludes my session today. I hope you got something out of it and enjoyed. And so Nicole, back to you.
Thank you so much, Amanda. I really appreciate you bringing light to an issue that is not often discussed, as well as providing us with some current resources. So we have a few more minutes left, so I'd like to take this time to ask you a few questions. But before we do that, can I ask you to move to our evaluation slide while we talk through these questions?
I can't find my mouse again, but I can do it.
Whenever you find it, feel free to just put it.
There are my citations. Evaluation.
Perfect. See, gotta love tech.
Yeah.
All right. So my first question for you is, how is stress different from PTSD?
Yeah, that's a good question. Because there's a lot of overlap, right, between anxiety symptoms, like I kind of talked about how they're kind of ugly cousins, but PTSD is actually an anxiety disorder. So it's kind of in the same family. But PTSD is a little bit different because someone with clinical PTSD has truly kind of experienced something horrific, right? Whether they saw something, heard something, maybe felt something that triggered kind of a fight or flight response. How our brain kind of manages trauma is just different than typical day-to-day anxiety. And our brains can just change how we deal with normal stimuli based on a traumatic experience. So they're just a little bit different.
Thank you for that clarification. That's very, very helpful. So my next question is, if someone thinks they have PTSD, what would you recommend that they do?
Yeah, that's another good question. If you have a social worker at your HTC, I think most HTCs do have social workers. I would highly recommend, calling them up. Social workers are good resources for finding long-term therapists, bouncing ideas off of them, and social workers can kind of help evaluate and walk you through whether you are showing signs or symptoms of trauma. But, I would recommend, again, like I said, mindfulness can really be used by anyone, as can therapy. Like anybody can go to therapy. You don't have to have like a specific diagnosis to want to start going to therapy. It can just be helpful, really just for anybody. So I would recommend, reaching out to your support network and to the social worker or your HTC.
I think those are some excellent recommendations as well. And then I have two more for you. So the next question is, how can spouses or support networks help those suffering with PTSD?
Yeah, that's another really good question. I would first say, for spouses, it can be hard, for sure, living with someone who has a past history of trauma. I would first say it's important to validate them, right? Like, wow, you've been through so much in your life. You can't change somebody, but you can absolutely validate them and make sure that, they feel heard, and come at it from a place, if you want to address it with them, come from a place of caring, using I statements, right? Maybe not in the heat of the moment when you're in an argument, you're really irritable today. Like, that's not going to go anywhere with anyone. Instead, maybe say, after the argument is over, you can say, like, I think you've been through a lot in your life, or I'm hearing that from you, and I really care about you. How can we figure this out? Like, what can we do to get you help that you might want? But you can't, you can lead a horse to water, you can't make it drink. And so it's important to recognize as spouses what you can and can't control, because we don't have control over everything. And also maybe spouses might want to get their own help, and their own, support themselves in their own way, and to reach out to their own support networks, because it can be really difficult for spouses too. But again, yeah, coming from a place of caring and love and validation, I think goes a long way.
Absolutely. Well, we only have a few more minutes left, and I'm still going to squeeze this question in. But my last question is, what advice would you give to anyone listening who may be suffering from PTSD but has hesitations or is either afraid to seek help?
Yeah, I mean, I think that's really common for people, to feel like they've failed in the past. I've tried it before, therapy didn't work. And, like I said, I think it's not necessarily curative. You need to learn how to live with the trauma and the past experiences. And you can do that in a way that's healthy, and you can incorporate it into your life and make sure that you're okay and move on and still have good relationships. So I would just say, don't be afraid to fail, and you probably will fail. And that's not a bad thing. It's okay to do that, to fail.
Thank you so much, Amanda. Again, we are out of time, unfortunately, but I can't thank you enough for your time and dedication to help create this session. We just genuinely appreciate your enthusiasm and your dedication to the community. And to the folks watching at home, thank you for joining us, and enjoy the rest of your conference. And please don't forget to complete the evaluation, and feel free to utilize the chat feature and ask Amanda questions. She'll be here to answer them. Take care, everyone. Bye.
Thank you.